Good afternoon. Welcome to another continuous medical education organized by Kurunegala Medical Association. Today, so we are changing our presentation style to cover more acute problems in medicine and surgery and pediatrics and obstetrics as well. So we are starting with cardiology emergency. So we are going to deal today acute coronary syndrome. So we have two speakers. So I'm delighted and privileged to introduce Dr. C.Hathlahawatta. He got his board certification as consultant cardiologist at 2009, and Dr. K. Sunthareshan, he got his board certification as consultant cardiologist in 2013. So I would welcome both to start this presentation. So it's going like Chintaka is starting the presentation, and then Sunthareshan is joining in halfway. So I would invite Chintaka to start. So enjoy the presentation.
Thank you, Nalaka, for your kind words of introduction. Good afternoon, everybody. It's a pleasure for me to be here today. And first of all, I'd like to thank the organizers, the president, and the organizers of Kurunegala Clinical Association for giving me this opportunity. Okay, before embarking on the topic itself, I'd like to share a story with you. This is Mr. Bandara Disanaga, 62-year-old gentleman from Alau. He got a chest pain about half an hour back, and he visits his GP, nearby GP. Luckily, the doctor there has a ECG machine, and he takes a ECG. So this is the ECG of Mr. Bandara. What do you think? There are subtle changes in these leads and chest leads. You can see significant ST changes. So my questions are, what is your diagnosis, and where to send the patient, and how are you going to manage this patient? So I'm not going to ask questions, so I'm not going to give you answers. At the end of the lecture, you will be able to tell me the answers. Acute coronary syndromes. Acute coronary syndromes. Syndrome is a broad term. Basically, what it implies is a acute block or acute obstruction of a coronary artery causing distal ischemia or muscle necrosis, myocardial necrosis distally due to acute obstruction of a coronary artery. Now you can see this vessel. Usually it's due to a plaque rupture. You can see a ruptured plaque here, causing thrombus formation or clot formation, obstructing the lumen, causing distal muscle necrosis. Depending on the degree of obstruction, traditionally we classify these syndromes, acute coronary syndromes, into 3 subtypes. So patient comes in chest pain, you do ECG, and then you will find in certain instances ST elevations in ECG. So that is ST elevated or ST elevation myocardial infarction. That is called STEMI. That is ST elevated myocardial infarction, STEMI. For certain people, they don't have ST elevation, but they have ST depressions, T inversions, or any other findings. Then you do a cardiac marker, troponin. Troponin is a cardiac marker which is inside the myocytes, cardiac cells, and it gets released once the muscle cell get damaged due to ischemia. So obviously, if you have positive troponin, that means there is significant muscle damage in the heart. So if the troponin is positive, then you call it non-ST elevated MI, where you don't have ST elevations but other ST changes. And if it is negative, then you call it a unstable angina with negative troponin. But my topic today is, what I am going to concentrate on is STEMI, ST elevated myocardial infarction today. So what is STEMI? Chest pain, the history, chest pain or chest discomfort, which is equivalent to chest pain. And you do ECG, you see ST elevations. You can do troponin, it's not a must. If you have history and ECG changes, acute ECG changes, that is good enough to make a definitive diagnosis. Now, supportive information can be taken if you can get an echo done, but it is again not essential. Now you can see the ST elevations in this ECG given here, typical ST segment elevation. So this is a real medical emergency. If you see a patient with chest pain, ECG like this, you don't have time to think actually. It's a real medical emergency. So what is the plan of management? The patient comes with the symptoms, onset or the maximum pain and the presentation within 12 hours. Within 12 hours. With the persistent ST elevation. ST elevations are there. Patient comes within 12 hours of the onset of the pain or the maximum pain. Then you plan for what is called reperfusion therapy. Reperfusion means relieving relieving the obstruction, tackling the obstruction, the block, which can be done in two ways, two means. First thing is pharmacological method, that is called fibrinolysis. The agent we have is tenecteplase T and K. So it's one of the best fibrinolytics available in the world. We are lucky enough to have this with us now. And the other option is mechanically, you can remove the obstruction and fix the lesion by doing what is called primary PCI. It is done in a cath lab center, a cath lab facility. That is invasive way of managing the problem. So the question comes, the $1 million question comes now, how do you decide whether this particular patient is going for medical or pharmacological fibrinolysis or invasive primary PCI? That is the question we have. It will depend on few factors. Now you diagnose the patient is having STEMI with ECG changes and the history. Then if there's a cath lab nearby, cath lab, access to cath lab is easy, then you directly send the patient to cath lab. Direct admission to cath lab without any barriers. Then we can do what is called primary PC, angiogram and PC. Or if you can transfer the patient roughly within 2 hours to a cath center, not within 2 hours, actually within 2 hours you have to get the patient to the cath lab and put the patient on the bed and put the lines on, and you have to wire the lesion. I'll tell you the procedure in a minute. For that you are given only 120 minutes, that is 2 hours. Within 2 hours, if you can get these things done, then you can plan for transfer this patient to a cath center where the staff there can open up the vessel quickly. But most of the time in our setting, our scenario is not that. It is pharmacological fibrinolysis, where you don't have a cath access within 2 hours, less than within 2 hours. So this is a cath lab. You can see it's a theater setting with sterile conditions. You do. Patient is not under general anesthesia, just maybe little sedation or local anesthesia. You can see a C-arm X-ray tube, and you do under fluoroscopic guidance. The procedure is being done under fluoroscopic guidance, under sterile procedure. So you can see an example of this is right coronary artery, where there's a acute block. So sudden cutoff of blood supply to the distal part of the right coronary artery territory. So then you can, if you can look at this very carefully, you can see a tiny wire going across this artery, right coronary artery. This has been tackled. The problem has been tackled and stent has been put. So you have, now you can see, compare the two pictures. Patient comes with acute block and within few minutes patient is back in normal circulation now, restored. So this is the gold standard, world best technique of tackling acute occlusion of coronary artery, but unfortunately we can't offer this option to each and every patient, not everywhere. I mean, not even in Western countries, not every each and every patient, due to the limitation of this facility. This is an example of a stent, coronary stent. Right? So we have time targets. Depending on the time targets, you have to decide the patient, whether this patient is sending for primary PCI or medically managed. FMC, what is FMC? FMC, first medical contact. Patient gives a call, paramedics in other countries, they visit the patient with an ambulance, and then within the ambulance, they can take ECG and make the diagnosis. So within few minutes, with first medical contact, they have the diagnosis. But here in our country, what happens is patient comes to either hospital or a private sector, then you do ECG. Ideally, you have to do this within 10 minutes of first medical contact. And ECG diagnosis can be made, and then if you are going for fibrinolysis, should be done within 10 minutes. Within 10 minutes, you have to get the vial and everything ready, and then intravenous administration. If you're sending, as I told you, the primary PCI center, the target is within 120 minutes, within 2 hours, the patient, the wire should be in, the lesion should be, I mean, the block should be practically open. From STEMI diagnosis to primary PCI, where the patient is in PCI center. For example, if the patient in this hospital, particular this Kurunegala hospital, where we have a cath lab facility, ideally we should be able to open up the vessel within an hour, 60 minutes. And if you are transferring the patient, transfer time maybe, they say maybe around 30 or so. So within 90 minutes, you should be able to open up the vessel in ideal setting. TNK, tenecteplase, is the drug we widely use here now in our country for medical or pharmacological fibrinolysis. It is given as an IV bolus for 5 seconds. Very quick action, very rapid onset. Easy to handle actually. The vial is there, the liquid or the solution is also given with the vial. So you can dissolve the dust powder, and then depending on the weight of the patient, you administer the dose as a bolus within 5 seconds. You can see this is depending on the weight, you calculate the dose for the patient. But importantly, if the patient is more than 75 years old, you calculate the dose normally, and then you give the half dose if the patient is more than 75 years. All right. Obviously, for any drug, you have contraindications. For thrombolysis, also you have contraindications. If the patient gives a previous history of ICH in the history, this is absolutely contraindicated. You can't give. Ischemic stroke within 6 months, last 6 months, or CNS damage, neoplasm, or AV malformation. Major trauma, major surgery, head injury within last month, 1 month's time, or active GI bleeding within 1 month, or non-compressible punctures, for example, liver biopsy or lumbar puncture within last 24 hours. Obviously, with bleeding disorders or aortic dissections, you can't offer this option. There are relative contraindications, especially if For example, if the pressure is very high, 180, 110 like pressures, it's not an absolute contraindication. You can control the pressure with IV, either GTN or nitroprusside, and then when the pressure is reasonably under control, you can administer safely. With high pressures, you should not do, because there's a high risk of intracranial hemorrhages if the pressure is high initially. But you have to bring down the pressure quickly and give this. And pregnancy, they say, is a relative contraindication. Pregnancy and within 1 week of after delivery, it's again relative. You can consider, depending on the situation, you can still consider giving TNK. So what happens after fibrinolysis? You give TNK intravenously, then after 1 hour or 1.5 hours time, 60 to 90 minutes, you repeat ECG and see whether you have done the job. Now, most of the time, you see appropriate, a reasonable ST resolution. ST, this is the ST segment, baseline before giving the treatment. And then after 1 hour, 1.5 hours time, if it has come down more than 50%, then you are successful. Otherwise, if it has not come down by 50%, then you call it failed thrombolysis or fibrinolysis. Or even before 1 hour, at any time, if the patient becomes hemodynamically unstable, stable patient suddenly become unstable with low blood pressure, maybe tachycardia, VT, or severe bradycardia, or worsening symptoms, severe angina, then you call it failed thrombolysis. And then what is the management plan? Then you need to consider urgent coronary angiogram. You transfer the patient, you get down the patient to cath lab, and then you do what is called rescue PCI. So management, regular management of this patient, ideally in a CCU or HTU facility where the patient is keep under ECG monitoring continuous up to 24 to 48 hours. With defibrillator facility, you need to have a defibrillator with you in an emergency for defibrillation. Oxygen usually is not essential for each and every patient. If the saturation is less than 90%, then you give oxygen. IV morphine, again, there are some issues, but generally, again, it's not a must. But if the patient is having significant pain or distress, then you can consider IV morphine or benzodiazepine even to relieve the pain and the distress. Antiplatelet agents are very important. Aspirin, we know, is a soluble form. Loading dose is 300 milligrams. You give stat on admission and then followed by 75 milligrams daily to continue. And clopidogrel, loading dose is 300 usually, followed by again 75 milligrams daily. But if the patient is more than 75 years of age, then you don't give loading dose 300, but instead you give 75 milligrams stat and then 75 in the night thereafter daily. We have newer drugs. Prasugrel is compared to clopidogrel, the onset of action is quick and the efficacy is better, but at the cost of bleeding risk. So you don't give, if the patient's age is above 75, you don't give Prasugrel, but otherwise, if it is available, you can give as a loading dose 60 milligram and then followed up by following that 10 milligrams daily in the daily. So ticagrelor is another drug which is available in the country, can be given as a bolus 180 milligram orally, followed by 90 milligrams twice a day. But Prasugrel again is contraindicated if the patient has a history of CVA, maybe ICH, maybe ischemic, and a TIA. And it's relatively contraindicated. We don't usually give if the patient is more than 75 years or the body weight is less than 60. You need not. So enoxaparin is an anticoagulant, which is again a very, very important agent in acute STEMI setting. If the patient's age is less than 75 years, then you give IV bolus of fixed dose, 30 milligrams IV bolus stat. Then in about 15 minutes time, you can give the regular dose of 1 milligram per kg subcutaneously. Can be continued as BD doses twice a day. If the age is more than 75, then you don't give IV bolus. IV bolus is not given, and the regular subcut dose or subcutaneous dose is 0.75, not 1 milligram, 0.75 milligrams per kg twice a day, until you do stenting or fixing of the lesion, or until the index of hospital admission, maybe 5 days, maybe up to 8 days they have studied. If the patient has got renal impairment, GFR less than 30, then the dose calculation is 1 milligram per kg per day, not BD, not twice a day, daily 1 milligram per kg. There are complications of MI, acute STEMI. Of course, certain people, they come with a severe pulmonary edema, heart failure, where you can manage with loop diuretics like furosemide, or patient might need CPAP or BiPAP ventilation or mechanical ventilation in severe conditions. The patient has a shock or hypotension, you have inotropic agents. Very rarely, you can consider IABP, intra-aortic balloon pump, to bail out. Intra-aortic balloon pump is you put a balloon into the aorta, and then you count a pulse. You inflate and deflate periodically the balloon, synchronizing the heart cycles. Thereby, it acts as a pump actually in the aorta. If the patient has a bradycardia, significant bradycardia, sinus bradycardia, or high degree heart blocks, you can try with atropine. Failing that, patient might need temporary pacing. You put a wire, and with the aid of a generator, you create an impulse, or you create an impulse in the right ventricle. That is called temporary pacing, electrical impulse. So mechanical complications, rare, but they have very high mortality. Acquired VST, free wall rupture, and mitral regurgitation. Free wall rupture is most of the time the patient won't survive, but these are the complications. And thromboembolic complications due to intracardiac or intramural thrombi embolization can give rise to CB or TIA. Hemorrhagic complication most of the time is usually due to our drugs, thrombolytics, anticoagulants, antiplatelets. We are giving very high doses. Some people, they can get complications due to this. So medications, beta blockers, these are essential drugs. Beta blockers, statin and ACE inhibitors. You should start if the patient is reasonably stable. If the pressure is all right, if the heart rate is all right, beta blockers, and statin high dose, not low dose. High dose statin can be started. So ACE inhibitors, captopril, enalapril, ramipil, or if the patient can't tolerate, you can go for ARB, angiotensin receptor blockers, losartan, telmisartan, valsartan. You should not combine these drugs. It's contraindicated. You can't combine captopril with losartan or something. MRA, mineralocorticoid receptor antagonist, spironolactone, should be given especially if the ejection fraction is less than 40. You need to manage sugar. If the sugar is more than 180, they say, with the appropriate agents. So of course, surgical options are there, especially if the patient, when you do angiogram, if the anatomy is not favorable for stenting or interventions, then you send for surgery. Depending on the stability, the urgency will differ. And mechanical complications, as I told you, like VST, acquired VST, you send for surgery. Surgical correction of the defect and the bypass, CABG. So this is also important. Cardiac rehabilitation. At the end, you send the patient home, and then you get down the patient back and see whether the patient has got any issues. You educate the patient. You get the patient's exercise tolerance assessed, and then you plan for exercise program. And at the same time, you do what is called coronary risk factor modification, long-term, lifelong, and especially very important dealing with psychosocial issues. This is not being done in normal routine clinics. So cardiac rehabilitation is actually an important part of the management of this condition. So that is all I have to tell you about this topic. To sum up, diagnosis of STEMI is mainly done by ECG. Within 12 hours of the symptoms, we consider reperfusion therapy, either pharmacologically or mechanically as primary PCI or TNK. Time targets you can remember: ECG 10 minutes, within less than 10 minutes, thrombolysis less than 10 minutes. You are sending the patient, transferring the patient, within 2 hours you have to open up the vessel. And if you are in a cath center, within an hour you have to answer, you have to tackle the problem. And enoxaparin, aspirin, clopidogrel, you can remember aspirin 300 milligrams stat for all patients and 75 thereafter. Clopidogrel 300 if the age is less than 75. And enoxaparin, IV bolus 30 milligrams if the patient is less than 75, and thereafter 1 milligram per kg twice a day. The patient has got renal impairment, 1 milligram per kg daily. And of course, we discussed about complications and surgical revascularization, and of course, the importance of cardiac rehabilitation. Thank you very much for your attention. If you have any questions, I can. Yes, the question is now whether the primary PCI is available in this setting. Answer is yes and no, because obviously one thing is we have only one cath lab. So obviously we are doing our routine list as well. So if a patient comes when we are doing a case, for example, if we are doing a planned PCI, it might take sometimes 1 hour, maybe more than that. During that period, if a patient comes for a primary PCI, then either we should think to give thrombolysis, or we can keep the patient outside. Once the case is over, we can take. But practically, most of the time, from ETU, we take the patient. In our working hours, we take the patient for primary PCI. We do a lot of primary PCI cases. But of course, before corona, yes, yeah. So we do a lot of primary cases. But 100%, as I told you, it's not practical at this moment because of the limitations. And but of course, we do facilitate it for rescue PCI. But if the patient is unstable after giving thrombolytics, then most of the time, almost like 100% we do. If the patient is there with us, then we do. We can do it within the given time.
Good afternoon, everybody. It's a great pleasure to be here. Thank you, Nalaka, for having me. I'm going to talk on the management strategy for non-STEMI that will be based on latest ESC guideline, which was published in 2020. Before I go into the topic, I would like to present a case. A 56-year-old male who presented with severe chest pain. The chest pain was radiated to neck pain, neck and bilateral arm. He was hemodynamically stable. The blood pressure was 110/70 and the pulse rate was 100 beats per minute. And he has got pansystolic murmur, which is suggestive of mitral regurgitation. And ECG was arranged. Subsequently, troponin also was arranged. This is his ECG. Is there anybody who would like to comment on the ECG? Because it's clear, very clear. There are ST depressions. Widespread ST depression, mainly more than 1 millimeter, ST depression. And if you carefully see, there's ST elevation in V1, as well as a mild ST elevation in AVR, which is highly significant. You should not overlook. And the troponin was arranged. the troponins became positive. So we generally come across like these patients, chest pain and some ECG changes. So we have to triage the patients. This is the diagnostic algorithm and triage in acute coronary syndrome. This acute coronary syndrome symptoms can vary from mild, stable patients without ECG changes to a significant chest pain or severe chest pain with ST depression or ST elevation with positive troponin. So you have to categorize which patient needs to be admitted to CCU, which patient needs to be admitted to ward, which patient can be discharged. If you see in this end, this patient, like our patient, has got severe chest pain with radiation, and he has got ST depressions, and the troponin was positive. So you have to rule in this patient by diagnosing non-STEMI. On the other hand, if you see these patients, this group of patients, SMILE symptoms, there's no ECG changes, and the troponin was negative. So this, we can easily rule out those patients. And we have to find alternative cause for, alternative non-cardiac cause for this pain. And then when we talk about rule out and rule in protocol, there's the way. So the best method is the 0 hour and 1 hour rule out and rule in protocol. There, when you suspect non-STEMI patients, you arrange troponin at 0 hour. 0 in the sense, when you meet the patient, when the patient get admitted, you have to arrange troponin, high sensitivity troponin, and then you have to repeat it after 1 hour. And if both are low, you can safely rule out, and then you can think of discharging the patient. The optional investigations are stress testing. In our setup, it is like exercise ECG, stress echo, or cardiac MR, CMR. And you may ask the patient to go for CCTA if suggestive of atypical chest pain. You can ask the patient to go for CT coronary angiogram or even invasive angiogram if it is relevant to investigate further. And if the 0 hour and 1 hour troponin is high, then obviously you have to rule in as non-STEMI and then admit the patient to CCU and arrange echocardiogram and, if possible, angiogram. But in between, you have to observe if there are some patients, they can come into this category, and those patients you admit to ward and do the 3rd hour high sensitivity troponin and echocardiography, and then you can decide later. So when we talk about the timeline, Chinta has told about STEMI guideline timeline. I just want to stress about this non-STEMI one. So here the patient comes, that is a 0 hour. You take the blood for high sensitivity troponin, and the turnaround time, that means the troponin results will be available in 1 hour. So by the 1 hour, you know whether this patient needs, whether that is a significant one or not. If it is positive or very high, then you admit this patient to the hospital. And if it is negative, repeat the patient's high sensitivity troponin after 1 hour. That means in the 2nd hour. So that results will be coming in 3rd hour. So 3rd hour troponin, if it is negative, by the 3rd hour, you know the troponin, the 2nd hour troponin, whether it is positive or not. Then you can safely rule out non-STEMI, and you can investigate or evaluate further for the assessment of non-cardiac cause. But say if it is positive at the 0 hour or the 1 hour troponin, then you have to rule in the patient and admit to ward or CCU for further management. In the acute setup, we generally use several medications, particularly antiplatelets and anticoagulants. I'm not going to go in detail about this one because Dr. Chinda has touched this. So we have treated our patient with antiplatelet and statins, admitted the patient to ICCU for continuous monitoring because we have to monitor the patient minimum 24 hours or till the patient goes for revascularization. An experiment was started and the routine blood tests were arranged, such as fasting blood sugar, full blood count, serum creatinine, and serum electrolytes. The echo revealed anteroseptal anterolateral hypokinesia from basal to distal cavity level, EF was 35%, and patient had mitral regurgitation. Mitral regurgitation in acute coronary syndrome can be due to various causes, such as ruptured chordae and tethering effect. There are various causes. And now the patient had ongoing chest pain. What will you do? Because obviously we have to treat the chest pain. The recommendation for anti-ischemic drugs in acute phase of non-ST elevation acute coronary syndromes are, you have to consider sublingual or IV nitrates and early initiation of beta blocker treatment for ongoing chest pain. And if the patient is already on beta blocker, you have to continue the beta blocker. You should not stop unless there is overt heart failure. And if the blood pressure is not controlled, if uncontrolled hypertension, then you have to consider IV nitrates. Or if the patient is heart failure, you can consider IV nitrates. In patients with suspected or confirmed vasospastic angina, you have to consider calcium channel blockers and nitrates, not the beta blockers. So our patient was started with beta blockers to achieve the target heart rate to 60 beats per minute. And the nitrates were started. AC inhibitors and MRA was started because ejection fraction was low, less than 40. And now you have to categorize the patient, whether the patient is in high risk category or very high risk category or high risk category, or we can do elective revascularization as elective. So an immediate invasive strategy less than 2 hours is recommended in patients with non-STEMI who have this following: hemodynamic instability or cardiogenic shock, recurrent refractory chest pain despite medical treatment, or life-threatening arrhythmias, VT, VF, and mechanical complications like myocardial rupture, papillary muscle rupture, VST, acquired VST, kind of things. And the heart failure, which is clearly due to non-STEMI, then you have to go for urgent revascularization. And then presence of ST segment depression, more than 1 millimeter in leads, more than 6 leads, additional to ST segment elevation in AVR or V1. This is like our patient. So our patient also had the similar ECG changes. ECG, ST depression was there, more than 6 leads, and there was mild ST elevation in AVR. And then some patients, we can take them within 24 hours. Those are the diagnosis of non-STEMI according to the previous protocol which I discussed, and the dynamic or presumably new continuous, the dynamic changes, STT changes, or trans in ST segment elevation, and a gray score, risk score of more than 140, that is assessed with various parameters. Some patients, then if you think that there's low risk, then you can arrange CT, coronary angiogram, and then leisurely you can do the angiogram and revascularization as planned. Now, our patient has got widespread ST depression with AVR ST elevation and ongoing severe chest pain. So we have arranged coronary angiogram. This was his right coronary artery. So if you see, there are minor irregularities in the, generally it's okay, the right coronary artery. When you see this left coronary artery, this is the left main coronary artery, and this is the left anterior descending artery. Here, this is the left circumflex artery. If you see, it's very tight stenosis in the distal LMC, and there's a tight stenosis at the ostium and as well as in the ostium of the LCX and the ostium of the LAD. See the degree of stenosis. You can predict this with the ECG. This is one clue. The widespread ST depressions with AVR ST elevation or V1 mild ST elevation suggest critical LAD or LMS stenosis. You should not miss that. Again, in some other view, you can clearly see the degree of obstruction. So there's no wonder that patient has got severe chest pain because hardly the flow in the left anterior descending artery. Now that patient has had complicated lesions, so he is waiting for inward CABG. I would like to touch on few things because generally we come across like how long we should continue dual antiplatelets. So if you mainly focus about this column, acute coronary syndrome patients who have undergone percutaneous coronary intervention, they need minimum 12 months of dual antiplatelet treatment. That is aspirin plus prasugrel or aspirin plus ticagrelor or aspirin plus clopidogrel. After 12 months, after 12 months, you have to assess the thrombotic burden. If it is high, then you can continue DAPT. That means dual antiplatelet treatment for till 30 months. Assess the bleeding risk. If the patient has got high bleeding risk, then DAPT is indicated for 6 months. Then after that, you can continue the single antiplatelet treatment. This is the criteria to assess the high thrombotic risk. It's a complex coronary artery disease with at least one criteria here, the diabetes mellitus requiring medications or history of recurrent MI, multivessel coronary artery disease or any associated vascular disease or premature disease. Those patients, you have to extend the DAPT treatment for 30 months if there's no increased bleeding risk. Right, then you have to assess the bleeding risk also. The bleeding risk can be assessed with major and minor criteria. I'm not going to tell in detail these things, but there's a chart. So you have to assess whether the patient is on long-term oral anticoagulant or any end-stage renal failure. Those patients have got high bleeding risk. So those patients you have to balance whether you have to assess the risk and benefit of continuing DAPT treatment. And when you see the acute coronary syndrome patient, because the first one we have seen the patients with acute coronary syndrome, they have undergone PCI. Now, when the patients plan for CABG and the patient was treated with CABG, then you have to continue the DAPT treatment again for 12 months. Then you can extend if there is high thrombotic risk, you can extend for more than till 30 months. And DAPT needs to be continued in the presence of high bleeding risk until 6 months. Then this algorithm for the dual DAPT treatment in patients with ACS undergoing medical management. In peripheral setup, we generally have like these patients. You assess the bleeding risk. If there is high bleeding risk, minimum at least more than 1 month you give DAPT. Then after that you can continue single antiplatelet treatment. But if there is no high bleeding risk, then you can continue the DAPT for 12 months and then you can extend if there's high thrombotic risk burden, or otherwise you can stop by DAPT in 12 months. There are some special situations. The patients with atrial fibrillation who are on warfarin, when the patients with AF undergoing PCI for non-STEMI, by default, you have to, in the ward, for the first week, you have to give triple therapy. That means oral anticoagulation, DAPT, that means aspirin, in our setup, aspirin plus clopidogrel. So in the first week, aspirin, clopidogrel, and warfarin. Then after 1 week, you should continue warfarin plus single antiplatelet, that is preferably clopidogrel, for 1 year. Then after 1 year, you have to continue warfarin alone. Then again, if there's bleeding risk, high bleeding risk, then triple therapy for first week and then double therapy for 6 months, not for 1 year. Then after that, you can continue warfarin alone. If there's high ischemic risk, triple therapy is continued for 1 month. And after that, you have to continue DAPT for 1 year and then single oral anticoagulant for the rest of the life. And generally, the other clinical issue is whether we can stop clopidogrel for the surgery. if it is an elective non-cardiac surgery, the clopidogrel should not be stopped within 1 month. You can stop after 6 months. In between first month, after 1 month to 6 months, you have to assess the risk and benefit. But you should not stop within 1 month for elective non-cardiac surgery. But you may stop if there's an urgent one. This is again another problem. So how long we should stop clopidogrel before the surgery, or how long we can stop the DAPT P2Y12 interruptions. So if it is clopidogrel, the earlier we know that generally there's a tradition that we stop 7 days prior to the surgery, but it's not 7 days actually. This 5th day, 5 days before the surgery, you can stop clopidogrel. If it is prasugrel, if the patient is on prasugrel, you have to stop 7 days prior to the surgery. And ticagrelor, 3 days prior to surgery. Aspirin, you should not stop during the surgery unless really indicated. And if the patient is having surgery involving high vascular areas, then you case by case, you can analyze and you can stop. Aspirin should not be stopped. And you can restart the treatments again within 1 to 4 days once the hemostasis achieved. This also Dr. Chinta has vaguely touched. I just want to tell all the non-STEMI patients needs to be screened for diabetes. If the blood sugar is more than 180, then they need to be treated with appropriate agents. And the main thing is the hypoglycemia should be prevented. And the statin is a common mistake. The common mistake actually. These statins are recommended in all non-STEMI patients. They aim to reduce LDL-C, LDL cholesterol by 50% from the baseline, or LDL of less than 55 milligram per deciliter. The people go wrong with the results because there is a range which is displayed in the report and they say that it's normal. So it is not like that. If there's non-STEMI, the patient's LDL should be less than 55. But if there's recurrent acute coronary syndrome, the LDL should be lowered further, less than 40. Right. The LDL cholesterol should be the LDL cholesterol target should be achieved within 4 to 6 weeks. If you can't achieve this LDL target while an optimized statin treatment, then ezetimibe can be added. If you can't achieve with both medications, then there's a drug called PCSK9 inhibitors, but that is not available in our country. This one I have told that if you, in the presence of recurrent non-STEMI or recurrent ACS, then you have to control the LDL less than 40 milligram per deciliter. And AC inhibitors or ARB, if they can't tolerate AC inhibitors, the ARB needs to be considered with heart failure, reduced ejection fraction less than 40%, diabetes, CKD unless contraindicated, severe renal impairment, hyperkalemia, contraindicated. And the beta blockers needs to be continued. If in the presence of angina, you have to anyway control the heart rate by using beta blockers. And the presence of heart failure, so mortality benefit, you have to start. And the patient is on previously, if the patient is already on beta blockers, they have to continue that. The MRAs, mineralocorticoid receptor antagonist, needs to be started if the ejection fraction is less than 40%. And the proton pump inhibitors can be started to reduce the bleeding. Summary, the management strategy for non-STEMI is initially you have to do the initial evaluation pathway to assess the symptoms, do the ECG, troponin, and try the patient, whether the patient needs to be in the CCU, ward, or observation, or you can discharge. Then diagnostic validation and risk assessment, assess the clinical symptoms, vital signs, and do the protocol, the high sensitivity troponins. And then you can direct the patients for early revascularization within 2 hours, or immediate one within the 2 hours, or within 24 hours, or an elective. And choice of antithrombotic, there are various medications available, which Dr. Chinta has told. And then invasive versus selective. The invasive, as I told earlier, there's immediate invasive patients needs to be sent for cath lab within 2 hours with those criteria. And then revascularization. After angiogram, some complicated lesions you should not treat in the presence of, mainly in the presence of diabetes. It should not be, the CABG is favorable than the PCI. You have to consider about the revascularization modalities. And then finally, after everything is done, you have to plan for the hospital discharge. The take-home message is DAPT for 12 months. If there's no bleeding, consider prolonged DAPT in the presence of high thrombotic burden and refer to cardiac rehabilitation. The main aspects needs to be addressed: lipid control, blood pressure control, diabetic control, tobacco cessation, and plant-based diet in ideal body weight. Thank you.
One question, actually. How much is the target of LDA? How long you are going to maintain it after in mind? You said 40, 55, and 40. Is it for 1 year or more than 1 year, or is it lifelong?
Because 30 months, 30 months there's a study, there are studies, but it is not minimum, at least for 2.5 years you have to manage. Early there was a concern about the intracranial bleeding because the low cholesterol level, but there's no significant association with that. So you have to continue long term.
They are tolerating that high amount of statin. Are you going to have release or relax about the target, or still you want to continue something different?
They can't tolerate statin. There are alternative options to start SSRIs. Like I said, they can't tolerate both of them. Then we don't have any other option. The tolerable dose we have to.
Do we have high sensitivity troponin here? We have high sensitivity troponins, but in our hospital we don't do the normal and regular, but it's available. But there are some issues with high sensitivity troponins also, because most of the time the indication is the problem. Sometimes you just do troponin for each and every patient. When it becomes positive, then you and the patient are in trouble. You have to repeat the troponin and see the rise. And cost is also involved. So many things. In ideal setting, you need actually high sensitivity troponin according to the guidelines in 1 hour, in 0, 1 hour, and 3 hours. After 3 hours, you send the patient out. You rule out the patient. In routine troponins, you can't do it. Even sometimes practically, what we do is in 6 hours we do troponin. In our regular troponins. Before that, sometimes troponin can become negative, can come as negative. But in 6 hours, it can become positive. So if you are going according to the guidelines, then you need high sensitivity.
In the high sensitivity troponin also, there are different methods of assessing high sensitivity troponin. The guidelines say more than 9, but different high sensitivity assessment has got different values. The interpretation is the problem. You should have the validated interpretation to rule out and rule. The marginally positives, they can come. The marginally positive, non-cardiac positive also can come as positive. So you need to carefully interpret.
Questions, Sundara and Professor. One is, what is the place of conflict in the long-term management of the other one is, as you call pressure and become a lot better than we have in plans to replace because we could replace streptokinase with PNP. Replace yeah, it's actually it has been discussed in our college level as well. One issue is the cost, very expensive, especially if you can go and also available outside, not in the government sector yet. But we are trying our best to get this done. Like streptokinase and TNK, the price gap is huge, but the outcomes, I mean, you can't sometimes. So we'll be able to get this agent actually, especially precedent. know that there are no major trials or major studies involved with both fast-track fish oil in the acute. For the heart failure, of course, there are small studies, but for the acute one, yeah, for you and the fish oils, there are some findings, researchers, but there are no hard evidence. Not in the guidelines. They say in acute cases, no. In chronic it was chronic and long-term management also, they say you may or you can consider something like that. It's not very, no, it's vague. All these, most of the time, all this depends on the financial pressures as well. Certain companies and all, they try to get into the field. But certainly they are not essential. You can consider some people, they ask to, I mean, they are symptomatic, if they are affordable, they ask for something, then sometimes we also tend to give this, not for each and every day. Thank you very much.
So in absence of education, so let me thank Dr. C.Hathlahawatta is actually our social secretary. So thank you very much, Chintak. It's a very short but very informative and it's excellently present. And Dr. Sunthareshan, same. So both did a good job. So thank you very much. And as appreciation, please accept this certificate. And thank you very much. And there will be no presentation for next Thursday because it's a public holiday. So we'll be having it in 2 weeks' time.